Good morning. I would like to join the previous speaker and thank you for being here this morning. So I'm Ilya Gipp, the Chief Medical Officer at Philips Healthcare. My talk today is going to be evaluating CT data in improving lung cancer outcomes. And I hope this is going to work. It does. There is a couple of things I need to do. Well, first of all, there is a disclaimer. I am working for Philips. My talk is paid and sponsored by my company. However, this talk is not going to be commercial. I will use some examples from my professional side. However, I'd rather talk about something I know than something I don't know. So those examples will be coming where I can from my company. There is some acknowledgements. And number one, I would like to thank Dr. Mayfield, William Mayfield from WellStar in Atlanta. He's a thoracic surgeon, one of the biggest influencer in my life in terms of lung cancer, and one of the reasons why I'm standing in front of you today. The other is the company. The company is Mevis. So they have contributed to me preparing this talk. Charlie Rahel is here as well. So I appreciate them also helping me with some of the content for this presentation, and I will show it to you in just a few minutes. Where I would like to start is CT chest imaging in with a CT, done with a CT in the US is done a lot. As a matter of fact, in one of the COVID years, 2021, there has been 85 million CT exams performed with close to 15,000 scanners. Now, that number is, of course, some approximation, but nevertheless, we're talking about something extremely, extremely large number. Now, the procedure mix, if I'm using at an average CT scanner in the US, is obviously, quite some is being done with low dose CT, about 5%, and that's again on average. And another 15% is coming from chest CT. So I would say 1 out of 5 patients where the chest is being scanned with a CT in the US. Now, every now and then there is a question, well, what about the ability to increase the amount of low dose CT studies on the CT scanners? And you see with the existing lower percentage of the amount of studies, so even if that number doubles, well, we're still probably not talking about the lack of CT machines. Again, I'm talking about the US, but I will be coming back to it as I'm also talking a little bit about the efficiency of the use of the CT in lung cancer. Now, my talk is about CT data, and I like to talk about data in an integrated manner. So the CT data in lung cancer management can be used for multiple reasons. And I would go in the course of my next 27 minutes, I will talk about what can it contribute to the better lung cancer outcomes. Now, in this room, for this audience, I don't need to talk about the importance of early detection. So when we talk about the CT in detecting lung cancer, we want it to be early in order for the outcomes to be better. So it all starts with early detection. And amongst early detection, there is 2 components that I always bring up. Number one is what can the CT bring in terms of pulmonary lung nodule incidental findings? I will get into screening in just a moment. But because more CTs are being used, or larger percentage of the CT use is for chest CT, or at least a part of the lung getting into the scanned volume, I believe there is also a greater potential to explore in terms of incidentally finding cancer earlier and then also detecting it earlier. So the other reason I very much enjoy talking about pulmonary lung nodules incidentally found is also the malignancy rate. There is multiple ways in how this can be explained, and I'm pretty sure this is not 100% right one, because you can find other publications probably giving us slightly different numbers. But in general, this is the paper that I like to see, and that it talks about the malignancy rate for incidentally found lung nodules. Not a very large study, but is close to 25%. So for something meaningful that is found incidentally as a lung nodule, 1 out of 4 appears eventually to be malignant and confirmed to be malignant. Now, when we are talking about lung cancer screening, so that malignancy rate is actually lower. So if we're looking for the actual actionable lung nodules, so the percentage in evaluating pulmonary nodules found with the screening is going around a few percent only. Again, there is not 100% truth as this, but in general, this is where also finding incidental nodules pays off in terms of detecting lung cancer with the better accuracy rate. The other part that we need to remember when talking about incidental lung nodules is this is just an example, an unfortunate one for the patient. And the reason for that is this is a study number one that was done. There is hardly anything that could be suspected here. But then over here, and especially if I toggle between the two, you can see that the lung nodule had appeared. Now, this was incidentally found. And as a matter of fact, the previous study was done for completely other reasons. And then, unfortunately, a couple of years after, this patient was scanned again, and there we are, we see the mass. So the chance to identify that nodule and follow up on that nodule was unfortunately missed. I also find it something that needs to be changed is that only 29% of incidentally detected nodules are actually being properly followed up. Now, this paper is not a new paper. It came out some years ago, but also from what I see and being in the US is that a lot of nodules go unfollowed. And that is another thing that the CT data can contribute for us detecting lung nodules, but unless they're properly followed up, the whole idea of the early detection is being missed by definition. If I'm going forward, incidental findings, early detection, then the next step is indeed lung cancer screening. Now, a lot has been said already about lung cancer screening and the role of the CT. So what I would like to do is just look at it from another perspective. Just a few days ago on Sunday, I was reminded of a great words actually from the sports industry, is the greatest ability is the availability. This is one of the projects that I've been busy with. A couple of previous years, we've been working with the government of New York in the rural area in Buffalo and Niagara Falls. And what we've done is we were able to create this program together with one of the cancer centers, together with the government of New York, local church, as well as the fire department, in bringing together technology and the ability to get to the patients and recruit these patients. This project is called ADDIE, which is a little bit ironical because yesterday we talked about the publication by David Addy. Well, here ADDIE stands for Early Detection Driven to You. It's actually something that is quite promising in my view by bringing CT and the screening towards the patients and being able to screen them where they are. The other part is the technology supports doing a better job by additionally reducing the dose without bringing too much noise into the images. Now, with this, I would like to advertise the next talk that is going to be after I finish and after we start the session on the volumetrics. It's not just about the noise, and it's not just about what the CT can deliver in terms of lower the dose and less the noise, but it's also about the accuracy of the CT. Now, in this case, I'm showing the reduction of the noise coming with the iterative reconstruction. So going from one generation to another, it substantially reduces the noise. Well, there is some projector features that are killing the idea, but nevertheless, you can see that image on the left is obviously more noisy than the image on the right. So for potential detection of the lung nodules, this could be beneficial. All right. Now, when we are dealing with the use of CT for lung cancer screening, we're dealing with a lot of data. Well, this data has to be processed. So screening by definition is something that is done on the massive scale. So I found this paper and actually enjoyed it very much to read it. So it talks about the enormous amount of data that comes with a CT. Now, if I'm reading, it actually talks about the average number of images obtained per patient per chest was 10.4, and it took the average scanning time was 34.6 minutes per patient. oh, wait a minute. So this paper came out when I came out, the same year that I was born and the same year that Star Wars came. So already then, people looked at the CT data and realized that this is something that they need to deal with. Now, the amount of data since then dramatically increased. If I'm looking at the paper, well, this is actually the video. I wonder if I can start it. Yep, I can start it. So this is the CT without the cover of the gantry. And here it is, it spins, and every spin generates 256 slices. So the amount of data that comes from the CT is increasing. So the amount of slices is increasing. So the amount of data becomes very large. All right, so this is the paper that again talks about the explosion in the amount of data in radiology, and the CT actually being in the lead. There was some time of exponential growth in the amount of images coming towards the radiologist. Now that slowed down, and when the paper was published, it was already talking about potentially reaching the plateau. But the reason for that was not because the equipment cannot generate more data. It was really because the ability of a human being to accept the information and to process the information has reached its limit. So if we're looking now, again, this data is from some years ago and is also for the US, but it talks about the radiologist needing to interpret at one image every 3 to 4 seconds in an 8-hour workday. How in the world could this be possible? With more data coming in, so we're talking about an image per second, what may we possibly expect as a high quality work by the radiologist? Well, and this is where the computers come into the game. And a lot's been said, and the previous speaker also referred to the ability of the computers to do the job. Well, I'm a radiologist, and I don't like to speak about computers as replacing me, but I like to talk about computers augmenting something that I can do better. So here is an example where the lung nodule is being followed up. Now, again, with making some reference to the next talk. So we consider that the data and the CT data, for example, in this case, is accurate enough so that the follow-up on the nodule becomes easier, the volumetrics become easier, and also the lung RADS report can be automated so that at least some of the functions that radiologist performs can be done faster, easier, and also more consistent, and something that we would expect from following up on the patient. Now, computers are supposed to help, and they do. Here's an example that was provided to me by Mevis. So talking about the manual interpretation of low-dose CT versus assisted. And I like the word assisted a lot, because that's where the CAD system, computer-aided, or the future AI applications come into the game. And what was reported in this paper, it's kind of not that easy to see, but you see the last column in the table that talks about the difference in seconds of interpreting the data set with lung cancer screening. So you can see that standard is non-assisted, and then dedicated is assistant, and then the difference. So we can see quite an improvement, at least what we would expect from CAD systems. Now, as a starting point, computer-aided lung nodule detection, there is quite a history about CAD systems it is. So you see this paper from 2005 that talked about the first generation of CAD systems that came into pulmonary lung nodule detection. So the idea is that 2005, they looked at what the CAD can do, and they realized that even with that level of CT resolution, quality, and the ability of machines to calculate and process the data, the problem is, well, false positives. So the machine can do a great job in generating information, but what of this information is actually true? Then the next paper that I found was in 2012, talking about the sensitivity being absolutely amazing, well, coming close to 96.7%. But a high number of false positives was once again detected. And then a lot recent paper came out and talking about that we can actually have a smaller size nodule or the smaller size, so the sensitivity to put at the highest But then also there is a limit to this, because if we go for the smallest nodules, then the amount of false positive is going to be a lot, as well as the radiologist will have to rule out more than they would actually be focusing on detecting. So therefore, computer-aided lung nodule detection is indeed a great support, but it has to be used in an intelligent manner. And hopefully the next generation that also comes with an AI tools and machine learning can also help us to do the job. Now that's a theory, but here is that theory being checked by another recent paper. I think this was just last year, when it was compared that the deep learning algorithm versus machine learning. And again, I'm a radiologist, I'm not a computer scientist, but what was reported is that the ground glass nodule is not detected by two different computer-aided detection tools based on classical machine learning methods, but is correctly detected by one based on deep learning. So there is a promise in AI, and I like to think that in the future, AI will also make the computer-aided detection and diagnosis easier. Now, there is a lot of other considerations that we have to keep in mind when bringing AI into a clinical practice. And for this morning talk, I'll just bring this image. I'm pretty sure that some of you saw this before. And what I like to talk to students when I'm giving a similar talk is that if the audience is not laughing, they are either saw this before or they're from the US. Because, well, all the diagnoses being missed and the lawsuits may potentially not be that funny, but the AI considerations are more than just the ability of AI to do the job. There is one other aspect before I move on beyond early detection and actually step into the diagnosis and staging with the CT, is that there is also an ability of machines to not even look for anything specific, but rather look for the features that might point to the future development of lung cancer. Now, this is the study that was put together by deep learning model. Basically, they loaded up a bunch of cases and let the machine decide. So knowing that those patients had finally developed lung cancer. So, and then retrospectively, okay, we'll try to predict lung cancer before there is signs of a lung nodule. A very interesting paper. I think somebody was already referring to this paper yesterday. Then the results were that CBEL, this is the name of the tool, can accurately predict an individual's future lung cancer risk from a single low-dose CT. Now, of course, there is a lot more other aspects that need to be taken into consideration. So, okay, well, now this is not really the risk group. This is the risk predicted from the CT itself. So when do we scan the patient? But it's an interesting development that I think needs to be taken into account every time we talk about the role of CT data in improving outcomes, because this is even the earliest than earlier detection. So I talked about early detection, now going into the next step, and that's diagnosis and staging. So for diagnosis and staging, the CT can be used for multiple reasons. Now, here is an example of a spectral CT, and that's the ability of the CT to detect multiple energies at the detector site. So simultaneous acquisition of polychromatic beam then is being separated into monochromatic beam. And here is an example of the two nodules. So two different nodules detected. You can see the one on the left and the one on the right. And then, well, can we try to judge on the malignancy of those? Well, spectral CT gives the possibility of actually looking at the iodine density and the concentration of a contrast. So if this becomes a contrast study, so the nodule on the left, and that's again coming simultaneously. So there's no separate study, separate CT that is needed. But the nodule on the left is demonstrating 2.1 milligram per milliliter average enhancement, the concentration of the iodine, and the nodule on the right is showing 0.6. Now, it's interesting that in this study, it was validated, and later on, they also did the PET-CT. So, and in the PET-CT, so they also seen that the malignancy on the left and no malignancy on the right. So the ability of spectral CT to contribute in the quantified manner to characterization of the lung nodules may potentially be the tool to help us sometimes avoid other tools and get to diagnosis and staging quicker. This is another example. Now, obviously here, we're no longer talking about the screening or early detection. So this is, well, the image on the left and the upper right is, upper left is the conventional CT, but the ability to have Z-effective, virtual non-contrast, and then also bringing this, enables us to see that the actual mass is inhomogeneous. So there is necrotic areas. So that may potentially influence and improve the clinical outcomes of the treatment pathway that will be selected. This can also be quantified. Therefore, the ability of the CT is potentially increasing by bringing multiple energies and the spectral capabilities at the same time. Another example of the use of spectral CT in diagnoses and staging is the enhanced lymph nodules. Now in this, I actually put an arrow where the lymph nodule is. With the conventional CT, it's very hard to judge whether there is contrast enhancement. However, if we do the monoenergetic, it becomes a little bit more visible. And then if I merge the conventional and iodine density, then we can clearly see that this nodule is involved, and there is obviously a process that is taking place that potentially for this lung cancer patient may be quite meaningful and decided on the treatment path. Now, to finalize the part about diagnosis and staging and the use of the CT, I would like to bring one more interesting paper. A couple of years ago in radiology, they had a wonderful review that talked about images being more than just images, or being actually data. And they used an example of lung cancer. They used an example of lung cancer in terms of selecting image features and extracting those image features that is not by the eye of the radiologist, but by the computer that can deal with a lot of various properties in the image. And what they figured out is that a total of 219 features that could be extracted from each non-small cell lung cancer, and they used the study on 235 patients. What I'm trying to say here is that radiologist's eye is a wonderful tool, but especially if we go into further mining of the CT data that could become even more meaningful, I believe this is also where the radiomics starts to play a greater role, and computers may help even further. Treatment guidance and navigation is the next area where the CT can be used and for sure should be used. This is an example of actually not just a diagnostic CT, but there was another talk yesterday talking about the cone beam CT during the intervention. So this is the cone beam CT used with the C-arm in the cath lab that provides the ability to image and identify the actual nodule, for example, for the biopsy, or to plan some intervention. For example, with the expert guide ablation, so during the ablation, and even to perform some of the measurements and real-time navigation and control of the procedure itself. The other part is we should never forget that the CT might look a little bit different. It might have a bigger bore, and then it is used for CT simulation during radiation therapy planning. So the CT data that is captured, that is allowing us to evaluate the motion, may also improve the accuracy of radiation therapy, which is a large part of what the CT contributes also to the clinical outcomes in lung cancer. An interesting discussion, actually right next to me in Emory, and just recently there was a TEDx talk, and this example was used for the general public and not really radiology or not really oncology public, the use of biomarkers in immunotherapy. Now, the problem with immunotherapy is that about 30% of patients respond to immunotherapy. Now, that's expensive, and that's limiting the possibilities for immunotherapy for a lot of other patients. So what they've done is they've looked at responders, so the patients that responded well to immunotherapy and non-responders, and then they talked about something that they called the twistedness of the vessels. With the use of the CT, this is a computer-based biomarker and data mining that is extracted from the data set. And then with quite a complicated math that I would not be able to explain, they found the features that point to the ability of us to predict the response or non-response of the patient to the upcoming immunotherapy. So a very interesting development by itself. But then if I also merge this with something I said earlier about 219 markers that were discovered and identified already in 2016, obviously there is a huge potential that I believe will also be defining the role of the CT in lung cancer in the next years to come. The last part, and this is where I will finish shortly, is the therapy assessment and follow-up. On one hand, the CT is a great tool to help us detect, stage, plan therapy, perform the therapy, and navigate, but it is just as important to also understand how the therapy worked. And the CT has a capability of actually doing that. So this is the improved detection of the recurrence of the lung cancer. Now, with the conventional CT, we see that there is something that looks like almost in the lumen of the bronchus. Now, is this adherent mucus? We really don't know. But then with the capability of that same detector-based multi-energy detection, we can clearly see that there is a contrast enhancement that's seen on the monoenergetic. You cannot miss this. And then also, if I'm going with the iodine density, the image in the middle on the right, and you can see that this is truly a lesion that was later on validated to be a recurrence of the small cell lung cancer. Another possibility is to use the CT and the capabilities of the quantified CT with spectral capabilities to look at the tumor response. So this is the patient that is undergoing a chemotherapy. There is a certain necrotic core. Now we can see even with the conventional image that there is some inhomogeneity, but can this be measured? So let's say if I'm performing this CT further down the pathway for the patient, will I be able to measure this? And you can see that, for example, conventional iodine density merged together allow me to clearly see and measure this necrotic core, and on the longer run to also evaluate how the treatment and how is the patient responding to this treatment. So what I also like to finish with is to talk about lung cancer data management. So using the CT as one of the pieces of the data that plays the role in lung cancer management. So of course the radiologist, and that's where it starts. And of course, radiologist plays an important role. And there is obviously lung nodule detection. There is various reports. There is various patient clinical data and even pathology reports that the patient has been biopsied. But then there is also a necessity to hand this information to nurse navigator and also manage this in terms of screening and incidentals, as well as support the tumor board management. So when the professionals are getting together, as well as performing some analytics to also help us to improve the functioning of the lung cancer service line, and then also linking this with clinical pathways. So what I'm trying to say here is without something efficient enough, even with where I started with incidental lung nodules, if we can do a best possible job in detecting lung nodules, but then they go unfollowed or not properly followed, or we don't know the patient did not show up for the follow-up, well, what use does it bring? So therefore, the CT is, of course, here, and that was the topic of my talk. The CT plays a significant role, but it also plays the role among the other infrastructure in the whole dedicated lung cancer data management system. So where I would like to finish my talk and conclude with a few thoughts is CT data is obviously playing a very significant role, is going to continue to play that role. And additional tools might obtain primary position in affecting outcomes. There is a lot of talks about potentially using liquid biopsy to evaluate risks prior to CT screening. All right, this is something that will for sure happen, but the CT position remains unchanged. It will still be a very useful tool to detect lung cancer. Amount of CT data will continue to grow. Maybe not in the amount of slices, maybe not in resolution, might be, but of course, with the ability to mine data and bring more radiological features out of the CT data sets, I think that it will grow and intelligent data processing and management will become imperative, if already not imperative today. Efficiency, safety, quality assurance, various legal issues, as it was mentioned by the previous speaker, need to be taken into account when implementing novel tools for CT data in lung cancer service lines. And with this, I very much thank you for your attention.